So I guess it's a minute past the hour, so I think we should start. Participation might be on the lower side because it's just the week prior to Thanksgiving. But we do record this session, and it will be available on our YouTube channel soon.
Okay.
So people will have access to this presentation.
That's perfect.
And usually that's how most people, that's how most people attend these sessions. They watch the recordings afterwards. So anyway, so without much ado, welcome all, and thank you for joining us today to welcome Dr. Yasir Rehman, who is presenting to us his research on.
Like the topic is about the.
I guess.
Yeah, sorry, can you guys
the
hear
expectations.
Me? Yes, expectation,
Yes.
and it's about the comparison between patient and surgeon's perspective and how it relates with the in terms of making the informed decision making with the for the patients. So thank you for your introduction. So I will start with my presentation. Here is a brief agenda for the presentation. Like we're going to talk about the introduction, methods, results, and discussion. And in the end, we will have some time for the question answer. So declaration, in terms of like, as you know that I'm associated with the Pain Center at the McMaster University in Hamilton, Ontario. But for this project, there was no funding involved. It was totally student-led project for my PhD, like it was a part of my PhD thesis. So there was no funding available. One of the declaration I have to make is that in the last minute, I made some changes and I sent forward the slides. So most probably that will be updated, but maybe you guys will see slightly like just 3 to 4 quotes different than what you guys have on the slides. But in other way, I can send you the updated slide after the presentation. So now, some of you who may know this gentleman and people who do not know, this is Simon Sinek. He is basically a motivational speaker, and the main focus of his speech, his speeches are that whenever you're starting something, you should start with why. Like why should be a driving force for you. It should be a curiosity for you, because when you have a why, when you think with starting with why, it always leads you to ask other questions that how some process can be accomplished, what is important to accomplish that process. So why should be the focus of your curiosity, should be the focus of your motivation. Let me give you guys an example. Like there's a scenario. The scenario is that let's say you guys are traveling on a highway or you're going somewhere and all of a sudden you get a flat tire. Let me tell you the reason why I chose this flat tire example, because the weather is changing, so I have to look for the snow tire. So this was some example readily came to my mind actually. So I use this as an example. So let's say you have a flat tire and you take it to the mechanic. The mechanic tells you that you need to change your tire. You have to replace the tire. Okay, now what? You decide to go with Michelin tire. Why you have to go with the Michelin tire or Goodyear tire? Because based upon your previous knowledge, based upon your previous experience, you are expecting that these tires were going to last longer for you. This assumption is based upon your previous experience, previous knowledge, because you know or you're expecting that these tires will give you good 3 to 4 years run for you. So that is something that you have measured and based upon the previous experiences, previous data available. But that is expectation because it is telling you what can happen in the future. It is telling you about some prognosis, some prediction. But is that really true that we all just go with the flow that mechanic tells us that you need to change a tire and you change the tire? Or at that time, you are expecting some information from the mechanic, because if it's a flat tire, they can patch it up, they can fix it. Why they have to change the tire, replace the tire right away? So here, if you guys look, the expectation is conveying a different meaning. It is telling you that you want some more information about it. It is coming about your perception now, because when you ask like why I have to change my tire, then you have another question that, okay, there are many brands available. Which tire should I buy? Shall I go with Michelin? Should I go with Goodyear? Should I go with Continental? So that is now another expectation, and that is about information seeking. So here, if you look, it's the same expectation word, but meanings, they have totally changed now. If you have the good information received and your expectations, they are fulfilled, your expectations, they are met, now this also has a predictive value now. It also attains the prognostic value for you. So now we talked about two expectations. One expectation is based upon your previous knowledge, prior experience. And that knowledge, that experience, you can measure, you can determine that, you can measure it, and it has a prognostic value. And that you do with the quantitative analysis. The other expectation is about information seeking. And as I already mentioned that, once you develop some perception, some understanding, and those expectations, they are met, they are fulfilled, that also tells you that, okay, this has some predictive value. Because if you, based upon the information, the example that I previously quoted, if you have bought a tire based upon the proper information, and you know that this tire can only last for 2 years as compared to 4 years, and if you have to change your tire after 2 years, you are still satisfied because you are already aware that this is not a good quality tire and the lifespan is going to be 2 years, not 4 years. So your expectations, they are met. So it keeps you satisfied, keeps you happy. So it also has a prognostic value, predictive value. But that you will have to measure it. You have to explore with qualitatively. You cannot measure with any scale. You have to explore that process. You have to get the meaning of this process. And that is what you do with the qualitative analysis or with the qualitative research. And both qualitative and the quantitative researches, they are important for your decision making. So now let's start with we are getting to our meat now. So the meat is about lumbar decompressive surgery. Why we if you have understanding about the lumbar decompressive surgery, this is an elective procedure. Elective procedure means that you do, based upon your risk versus benefit, you don't have to go for that surgery. It is not like a displaced femur fracture where the surgery is the only option when you have an open displaced femur fracture. Or if you have a cauda syndrome because of cancer, so you have to operate these patients in emergency because the options for your treatment, they are very limited. But this is elective procedure. It is mainly offered to the patients, mainly commonly conditioned. The common conditions, they are lumbar disc herniation, spinal stenosis. If you guys read about the literature, in literature, the outcomes, they are usually good. However, about 10 to 20%, and some literature, they also say about up to 40%, these patients, they are not satisfied with their outcome. So you guys can imagine, that there is a very wide variation in terms of the results. There's a lot of risk can be associated. So in terms of the risk and elective procedure, do you think like it is necessary for a patient to have a good understanding what this surgery is supposed to do for them? What will be their outcome? What are the expectations when they walk into the doctor's or surgeon's office, what they're expecting? So I think, yes, this is important. And about the lumbar decompressive surgery, particularly about the spinal stenosis and the lumbar disc herniation, one important thing we all have to understand, the goal of surgery is to relieve leg pain, not back pain. A lot of the time when these patients, they come, they have both leg symptoms and back problem. So they think that, okay, there's a very strong association. Oh, well, to some extent, there could be some association between leg and back pain, but the surgery is not indicated for your back pain, it is indicated for your leg pain. Now, how you would address that concern with patients? So now it leads back to why I have to choose this study design. Well, that was my thesis project. So, but other than being thesis project, there must be some rationale why I've decided for this project. And for that process, the reason is that, as I already mentioned, that if you look at the natural course of the disease, for example, lumbar disc herniation, you will read, like what literature says, that about 90% of these patients, they get better within the first 6 months, and the recovery continues up to 1 year with the conservative treatment, which means like you guys can give them, these patients, gabapentin, some physiotherapy, chiro, osteopathic treatment, like manipulative treatment. Maximum recovery you will see in the first 6 months, but it can continue up till the next 12 months. But the important thing over here is that when we look at the data, most of the researches, they are done in the post-operative patients. Now, what's the problem when you look at the expectation in the post-operative patient? The main challenge is that when you look in the post-operative patient, your outcome usually confounds your opinion about your preoperative appointments. If you have a very good outcome after the surgery, patient will say, well, my surgeon was an angel. And if you do not have a good outcome, and despite the surgeon has explained everything to you, because your outcome was not good, you will say that, well, my surgeon was in a rush, he was not a good surgeon, he was not listening to me, he was waiting to see other patients. Maybe he has done a good job, but patients post-operative they are confounding the recall of the information, and it's a kind of bias for them. Secondly, we need to compare the perspective between patients and surgeons, what they think is important from the patient point of view, and what surgeons think is important for the patient. When you look in the literature, in the preoperative patients, patients who have been elected for the surgery, there is no research was available when I was doing this study. There were some studies they were available, which were in the mixed population. When you have a mixed population, like some of them, they needed surgery, like surgery was the only option. Some of them, they were like with the back problem or with physiotherapy. So it was very mixed population. So we need something very unique sample which can give you some information in relation to surgery, because this is elective procedure. We have some still alternative treatment options available. So that was our goal. So now when patients they develop lumbar disc herniation, spinal stenosis, one thing you have to understand, my research is based on the Canadian healthcare system, which is slightly than the US healthcare system, because our most of investigations, they are covered by our provincial healthcare plan. Like if I have to go for the search for the investigation, I don't pay anything. My insurance does not pay. It is a province will pay for, the government will pay for my investigations. So it's it's a very positive thing, but one downside is that this brings long wait time. Usually patients, when they have to wait for MRI, it takes 3 months for them to get their appointment. And the surgeons, for the surgeon referral, the wait list is anywhere between 6 months to 1 year. And even some patients, like some surgeons, they have a longer wait list time. So when patients have developed sciatica, lumbar spinal stenosis, they have already developed pain, disability, restriction in daily living. They have developed some negative feelings. They have tried physiotherapy. So now they have developed some expectation that what they want to go, when they go for their consultation, so they want some relevant information for them. Now, what is that preoperative expectation that they walk into the surgeon's office? What surgeons think that patient might be interested to know about their condition or about the surgical process? And the third goal is that whether the information that is shared with patient, is that sufficient to make good decision for to elect surgery? So now, in terms of the research question, before we start presentation, I was having some discussion. So the spider, like in quantitative study, commonly we use the framework we use PICO, patient intervention, comparison, outcome, timing, setting. Um, and the reason is that because in observational study, we are measuring some intervention, outcome, or the natural course of the disease. But in qualitative study, that is not the case because we are not employing an intervention. We are not comparing the population in a way that we do in like in terms of the causal and the association pathway. So we use different framework over here. And the reason is that the qualitative study, in qualitative study, we answer another question, which we consider as a sub-question. For example, in quantitative study, you stop at the outcome. But in qualitative study, we have to answer one another or few other sub-questions. For example, we're going to talk about like what could be the sub-question in my research. So the sample was, we were looking for patients who are preoperative patients for the lumbar decompressive surgery, and they and their 6 surgeons. The phenomena of interest was like, what is the preoperative expectation and what information surgeons provide them? So that is basically the main question. Design is the inductive content analysis. I'm going to talk about the inductive content analysis shortly. Evaluation. Now, this is our sub question, that the information where they are getting from the surgeons, whether this meets their expectations. Is there any discrepancy between what they want to know and what surgeons think is important for these patients, and how it is related to their decision making? So this becomes a sub question. This could be one sub question, this could be multiple sub question, and the research is the qualitative study. So in terms of the method, we recruited 12 patients and 6 surgeons using the convenience sampling. For the interviews, we made separate questionnaire for surgeons as well as for the patients. And for that, we collaborated with a researcher in like expert in qualitative study, ethicists, researchers in the quantitative study, and spine surgeons. And so for the research, the questionnaires, we have to go like quite a few times in order to finalize our questions. All questions, they were semi-structured, which means that you can change your question based upon the discussion. They were not 100, like that is the leverage that we get with the semi-structured interviews or the questionnaires. All interviews, they were recorded, and I personally conducted all the interviews with patients as well as with surgeons. And after the interview, those interviews, they were transcribed in verbatim, word by word, that the way they were recorded. Then we did independent coding. We did actually duplicate like myself and one other colleague. We read those transcripts separately. We categorized them with a short phrase. We look for the common themes, how those common themes, they are related with each other, and we look for the meaning. And then we compared that, are we on the same page? Do we have do we have any discrepancies? So then we needed to discuss them. And member checking is one of the methodology in qualitative studies. Not everyone does it. It is basically, once you have completed your findings, you send your findings back to all the research participants and take their feedback, that what they think about those findings. So that is called as member checking. So the main methodology that we used to analyze the data was the qualitative content analysis. So as I said, like our interviews, they were semi-structured interviews. So the semi-structured interviews means that you do not have to go in the same order of the question that you have on the questionnaire. Your question, you can change your question order based upon the discussion, and even sometimes you have to make a new question based upon the discussion that even may not be the part of your questionnaire. So when you get this information, it is basically all over the place. So that's why you do the coding. You organize them in a categories, and from those categories, you look for the important themes. And then you look for those themes, look for their meanings, the relations are between those patterns, and you define your key finding. So that is the quantitative content analysis, and that methodology is more suitable when the prior knowledge is limited or scant, and you want to make your interpretation based upon the data you're receiving. And as already mentioned that in the preoperative surgical patients, data was very sparse when I was doing this study. So the qualitative content analysis becomes the more suitable study design or for this study. So in terms of the participants, we have 12 participants and 6 surgeons. The average age was 48 years, male, predominantly male. Lumbar disc herniation was the main condition, like was a surgical condition. And if you guys look over here, these patients, like 41% of these patients, they were either on sick leave, either they took early retirement because of their symptoms, or they were on long-term disabilities. In terms of the surgeons, the average age for the surgeon was 50. The average duration of their practice was 17 years, little above 17 years, and each surgeon performed these surgical procedures, at least 1 to 3 surgical procedures on a weekly basis. So the important thing is that these surgeons, they were well aware, they were quite involved with this surgical procedures and with these patients. So their value, their opinion was very important for us. In terms of the consultation, the average duration of the surgical consultation was 45 to 60 minutes. And these patients, surgeons, they always allow time for patients to ask questions. Second thing is that the decision to make, a decision to go for the surgery that was not required right at that during their first appointment. These patients, they were given time. So for example, one surgeon said that I tell my patients that we have talked a lot of things here. Maybe you should go home, contemplate, and think about what you don't have to decide or rush on the spot. So surgeons, they were trying to give them time to think, to assimilate that information. Now, in terms of like how they explain those surgical about those conditions, so surgeons, they use different strategies. They use spinal models in their office to describe what a lumbar disc herniation or spinal stenosis is. How they're gonna they use MRI scans, like patients' own scan, to explain their condition. They talked about the surgical procedure using the same model. Talked about the anesthesia, etc. And mainly they talked about the basic demographics, such as what is the success rate, what are the important complications, and the recovery time. That was what most surgeons, they thought patients need in their first preoperative appointment. Now, if we compare patients and surgeons' perspective, there you see a little bit let's compare patients and surgeons' perspective. In terms of the preoperative expectations, patients, their ideal situation for the patients is that when they go for surgery, they are hoping that when surgery is offered to them, the surgery will take care of both leg pain and back pain, and they want 100% complete recovery. Surgeons, they know that these patients, they are overly optimistic because surgeons clearly understand patients comes with recovery in both leg and back symptoms. But surgeons think that this is overly optimistic because we already discussed that the surgery is for the leg problem, not for the back problem. So often patients think their symptoms will go away 100%. So that's the expectation I do try to dampen down because it is not realistic. The other surgeons say that saying that 90% of my patients are happy they had surgery. The 90% don't necessarily get all better, but they are improved from where they were. So surgeons, they tell them that improvement is a possibility, but complete recovery, where you think that you're going to get complete 100% better, that is overly optimistic. That may not be the case in every single patient. Now, in terms of like what patients they are mostly fearful about, so that is something where both patients and surgeons, like we find like there was a very good concordance because both patient and surgeon, their main concern was that patients, they are mainly worried about getting paralyzed or not getting better. So that was the main area where they have the same same opinion. In terms of the surgeons during the preoperative consultation, surgeons think that it is more important to tell patients about the surgical procedure, about their condition, about the complications, anesthesia. Well, that's mainly done by the anesthesia specialist, but just briefly, like whether they're going to use spinal or general, just very brief discussion about that, and a little bit about, and some discussion about the recovery of their outcome. This, whereas when you compare the patient perspective, patients say that, okay, yes, they talk to us about the success rate and complications, but we want to know more about the post-operative activities. What kind of activities after the surgery we will be able to do, what kind of modification we need to do, whether we will be able to continue our same job, we have to modify our jobs, what is the long-term prognosis? Now, the patient says there was never a talk about the outcome being bad. No, I wouldn't even have considered the surgery, like it's been explained to me that 99% or whatever percent should be better. Okay. Now, in terms of the understanding about the consultation, surgeons, all surgeons, they say that mostly patients, when they leave their office, they do not have a good understanding about their consultation, about their condition, about the surgery. And surgeons, they also said that almost all the surgeons said that these patients, when they have accompanying guests, like their family members, friends, they usually develop better understanding about patients' condition and surgical process as compared to patients themselves. But now when we look on the other side for the patients, do you think that if you have a lack of understanding or your understanding is not sufficient about your condition, is that going to bother you? Are you going to be worried about that you have a consultation but you do not have a full understanding and you're going for the surgery? Probably yes, and most of us will think about that. But interestingly, these patients, they were not bothered by having sufficient information. They were happy. Almost all patients say that, well, my surgeon was really good and I was very happy. He explained everything to me. But when I said, okay, if he explained everything to you, can you please tell me what your condition, tell me a little bit, give me some summary of your surgery, about your condition. I just need a little bit description. Now, they were blank at that time. My doctor told me, but I can't remember the name. It's like extrusion. They are going for the surgery. They are happy about the surgery, but they do not have full understanding. Okay. So now let's look from the different perspective, from the different angle. We have patients on one side and surgeons on the other side. As already mentioned, that patients, they develop, like after lumbar disc herniation or spinal stenosis, they have developed disability, pain is there. They have tried conservative treatment. They have waited for at least 3 to 4 months for their MRI and waited for the surgeon's appointment. So sorry, sorry for that. So now they have already developed some expectations, some belief about their condition. So they have gone through a lot of psychological stress. They are emotionally, they are overwhelmed because of their symptoms. So one surgeon said that my mood is getting low day by day, and now I understand why people with pain are all depressed. The less I do, the more I get depressed. On the other hand, surgeons, they explain the symptoms, explain surgery, they explain procedure, risk about the surgery. But patients, they do not have the recall of this information. So we looked at the barrier. What are the common barriers in their poor understanding? So one important thing was that these patients, when they come, as I said, like they have a lot of psychological and emotional stress. So because of that emotional stress, they do not want to listen too much from the doctor, from the surgeon. And when they walk into the surgeon's office, they are preconceived. They are already expecting that surgeon will offer them the surgery, and that is what they want to hear. They do not want to hear too much about the risk and benefits and complications and long-term complications and the recurrence, although they want to, but during the appointment, they just want surgeon to tell them surgery is the answer for your condition. So surgeons, they invite patients for the decision making. They allow them time to ask them questions. If they have any question about their condition or surgery, they are not concerned about the lack of the information. And that's what patient says. As soon as surgeon said he'll do a surgery, there was a smile and I was happy, and a lot of the stuff went out of my head because I was expecting to get him to do it. He did not say much about that either regarding the long-term outcomes or the prognosis. But that is in the next slide, we're going to take a little bit interesting twist. So stay tuned for one slide after the next slide. So surgeons, they try to give the realistic expectations, but patients, they are overly optimistic. We have already discussed that. The best scenario would be that I don't have any more back pain, don't have any more numbness, weakness, or pain going down my leg, that I get back to walking, just back to normal life, right? So normalcy in function, stopping the medication, like completely free of the medication, that is basically their goal. In terms of these patients, now in terms of the decision, patients want to discuss their condition, their surgery, those important questions with their family members, with their friends, particularly with those who have already gone through the similar surgeries. They want to talk to the other healthcare provider, particularly family physician. And why not? Because you have known your family physician for a long time. You have a better rapport with them. You trust your family physician better than a surgeon that you just saw for the first time. And you go for the internet, particularly when you are not sure or you do not have full information about certain aspects of the appointment. But about the internet, some patients, they were saying that they acknowledge that the information on the internet cannot be 100% reliable. I'd like to see this information come from the surgeon, as Dr. Google is not always a good way to go. Surgeons, they also agree that these are the measures that patients, they will take in order to make decision for them. But interestingly, there was a very interesting finding that came from all the surgeons. And as I said, like, we use a semi-structured interview because it allows you to ask questions that are not part of your first questionnaire, but if it's relevant, you can ask additional questions. So that is the importance of the semi-structured interviews. So I added that question, that what is the role of family physician in terms of patients' decision making? And the surgeon says that it can be very conflicting. The reason is that why it can be conflicting, because a lot of the times surgeons, they tell their patient they tell their patients that because family physicians, they only see their this report, not they do not have access to the images. So they sometimes they tell patients that you need a surgery, whereas that patient, when they look at these images, this patient is not a surgical candidate. Now it's a problem because patient has walked in with the expectation by the family physician that you need a surgery. But on the other hand, sometimes patients, family physicians, they tell patients that you don't need a surgery. And when you look at the images in the consultation, that person is a surgical candidate. Now, you tell them you need a surgery. He says that my family physician says, no, you don't need a surgery. Now, another challenge, how are you going to tackle, how are you going to address that issue now? So that's why they say that family physicians, sometimes they can play a very conflicting role. So one surgeon's code is here. Some family physicians have already told them, don't have the surgery. And I find that irritating because why are you sending the guy to a surgeon when you have already told them not to have a surgery? So this is basically a big challenge in terms of when patient get stuck between what family physician is saying and what surgeon as a specialist is saying. So patients, they get double messages during this situation. Okay, so we look for some variation, we find some variation between patients versus patient. We also look for some variation between surgeons versus surgeon, and some variation like the incongruence between patient versus surgeon. So I think we have already discussed a lot about the incongruence between patient versus surgeon. So on this slide, I will not talk about a lot about that, but patient versus patient. The important variation between these 12 patients, what I found that patients who had a healthcare background, for example, I have one patient who had a background in human anatomy. One patient was nurse in the operating operating rooms, and one patient was already working at the Hamilton Health Sciences. So these patients, they have already some kind of familiarity with this process. So their understanding was better, but not the other. So in real practice, do we see every single patient who comes with this background, with the health-related background? So what do you think that the information that we're trying to give to these patients, is it uniform for all patients that we see in practice? Is it easily understandable for all these patients? So that's a question mark now. In terms of recall of the post-operating activity, so one patient, when I was interviewing him, he said that my patients never talked to me. Like when I asked him that, did he talk to you about the long-term prognosis and the outcome and the recurrence? And he said, no, he did not talk to me about that. And when I was asking him that, can you please explain a little bit about the consultation? Like just give me some summary. During that summary, he said that, yes, he talked to me about the outcome can be bad. It cannot be 100% recovery. So now there's another question. First of all, some patients, they totally denied that there was no discussion about it. So that is still holding true. But the other question is that if the doctor has told these patients about the long-term outcome, but patient says, no, he did not tell him, but then after some time, he says that, no, we had a discussion. So does it make you worry about that? How this concern should be addressed? How patients want to learn about this information and data about the other patients, because some patients, they say like surgeons are only giving us data about in the literature 90% success rate and 10% complication rate. We want real life data from your practice. In your practice, how these patients they are doing. What is in your practices, how is and the reason for that is because every surgeon's experience is different. Some surgeons, they are very experienced. Some surgeons, they are going through like their beginning and they're in the learning curve. So we want to know about your data, that how your patients they are doing as compared to what is published in the previous literature, in the previous studies. I think that is a very valid point. In terms of the surgeons versus surgeons, some surgeons, they also had some variation, particularly in terms of the screening criteria. Like one surgeon said that when patient comes to my office, before I talk to him, I gave him a questionnaire. In that questionnaire, I ask about all the medical history from these patients. There are some human body diagrams are there. I ask them 4-point mark everywhere where you are feeling pain. He says that if the person has, let's say, neck pain, back pain, bad hip, depression, endometriosis, fibromyalgia. So he said, I tell these patients that surgery is not going to be helpful for you because you have a lot of other problems. Actually, surgery can even make your symptoms worse. Basically, you may feel like even worse after the surgery. So it is better that let's go and address those issues one by one. Treat your depression first, treat your fibromyalgia first, get them under control, and then we can talk about the we can talk about the surgery. The other surgeon said that he was working for 25 to 30 years with a physiotherapist who was expert in treating back problems. So he said, whenever my patients, they are referred to me by family physician, all of my patients, they have to go through that physiotherapy for 3 months. During those 3 months, they will get all the treatments. And by the time they come to me from their physiotherapist, these patients, they are all surgical candidates, and surgeons, they have explained them about their back problems, so they have a good understanding. The same surgeon also did something very different. He says that 1 week or 2 weeks prior to patients' surgeries, I call like a small group of patients, their family members or friends, they are welcome if they want to bring them. And I have a nurse who will do a lecture, who will then explain the surgical procedure in the preoperative, like an education session. It was very unfortunate that we have a very unique variation from the 2 surgeons, but unfortunately, I really wanted to interview patients from those 2 surgeons, but one surgeon retired 1 week after my interview, and the other surgeon, I did not get any patient from him, but otherwise I would say that that would be a very important variation to report or capture in this for this study. Some surgeons say that when patients are not happy, we offer second opinion. Some patients say that, okay, if you do not want, or like in terms of the second opinion, we will refer you back to your family physician, and then they recommend family physician to set up a second opinion. Now it goes back to the same waiting time, 5-6 months to 1 year time. Patient has to wait another 6 months. Your symptoms may get better, get worse, because recurrence is possible. What happens, you don't know. So how this is changing your expectation, this can be another challenge. And in terms of explaining post-operative activities and the long-term outcome, some surgeons, they say that we usually don't do this in the preoperative appointment, because in the preoperative appointment, patients, they want to know mostly about their surgery, complications, healing time, but we discuss those post-operative outcome when patients come for their first post-operative appointment. But now the question is that something that is supposed to affect your prognosis in long term is not that important that you decide, you get that information prior to your decision making for the surgery. Because after the surgery, even if I tell someone that your symptom may not get better 100%, surgery is already done. You cannot reverse that process now. It is already done. The decision is already made. And one surgeon said that I just briefly talk about, not specifically about the long term, but I just give them some brief idea. If patients, they want to know, then they ask the question, I will address them. They're concerned about long-term prognosis, recurrence, but I usually don't volunteer that information unless patient asks me that question. And in terms of the incongruence between patient and surgeons, I think we have already discussed that. So I will move to the next slide. The other thing is that the other important thing is that as I said, like we did some member checking. We send out our information findings back to all the surgeons and the patients. The patients' remarks, they were uniform. They all agree with the findings. So I am not representing patients' finding over here, but the surgeon findings, they let's see what what are the important comments? One surgeon replied that the theme seems very consistent with what I deal with on a regular basis. Despite explaining everything with the help of patients, images, and or models, I'm surprised how little they actually take home. So that surgeon already knew that he acknowledges that there is a problem in terms of the patient's understanding and how we are explaining that process to them. But now, on the other hand, let's see the second comment. The second comment is, hence perplexed by the comment that they expect low back pain to get better, find it strange that they did not understand the condition. So I have shortened, if you guys look, I've used the dotted dots over here because it was a long sentence just to make sure. He also said that I'm surprised that we use so many models, so many ways, MRI scan, and still they don't understand their condition. So now here is something I think that we've already noticed, that there is a gap, because what patient wants, surgeon does not acknowledge that, and what surgeons they are trying to establish, patient is not understanding it. So there is a big gap now over here. So in terms of the discussion, like in summary, to wrap up, our studies basically shows that there are important discrepancies between patients understanding and what surgeons they try to establish with them. So there's a very, like, there was some important variation or discrepancies they were noticed because of their emotional stress, because of their psychological stress. These patients, it is hard for them to assimilate the information that is given to by the surgeons, and most patients, they wanted information either they can be given to them in the form of written, like in the written form, such as information pamphlets or brochures. And even one patient said that it will be better that if surgeons, they gave us some educational CDs or DVDs so that we can go and watch it at our comfort level. So that is also, I would say, one of the very important alternative that we can adopt in our practice, basically. And one of the important, as I say, like the communication is extremely important, because when we look at the challenges between the surgeons and the family physician, like the conflicting role about the family physician, this is one important challenge that we have to look for. Like we have to find means to address that conflict or that challenge. The key home take message in terms of our strengths, we, as I already mentioned, that we did comparison between both surgeons and patients' expectations, their perspective, and that was the first time that we did when I was doing that study. We did all the coding independently, and we did the member checking. In terms of the limitation, our study has a small sample size, but in terms of the qualitative study, we continue our interviews till we get to the thematic analysis. We got thematic saturation, not in thematic saturation. We got to the thematic saturation around 12 interviews, and we still did 2 more interviews just to make sure that we are not missing any important theme, and no new theme emerged. So we thought that 12 patients is like a good number for our qualitative study. The key message, or the take-home message, is that patients, they are overly optimistic, which may not be realistic. Patients, they want more information than just listening about their surgery or the condition. And most important is that because of their pain, disability, the reason why patient opt for the surgery is based on their pain and disability, which overshadows their desire, their need to know more about their condition, about the more information about the surgery. So thank you very much. Any question? I'm happy to answer your questions.
Well, I will have a go at it then. Oh, Ms. Sublet has a question. How much do family members help in the understanding of the condition and potential outcomes?
So that is really variable, because it mainly depends upon whether your family member has this kind of condition previously, or whether they went for this kind of surgery or not. But it's not only about in terms of like explaining those conditions to them. It is also family member. It also play roles in terms of like a moral support for them. Like, for example, okay, why not you go for the surgery? You have tried so many things. So just to give them a little bit more control, more confident. So that is basically the also another reason for which they want to discuss with their family member. But in terms of like how much support, that is variable from person to person. It depends upon whether family members they have experienced the same condition or not.
Well, thank you, Dr. Rahman, for that response. I have a methodology question.
Sure.
So you used an unstructured questionnaire.
It's
How many
semi-structured. Yes.
sorry about that. Yeah, thanks for the important distinction. How many times did you have to, like, ad lib questions? And did you try to marry the ad lib questions to your themes, or did you analyze those answers separately?
No, okay. So the thing is that like not every single time, but like for example, with the patients, sorry, with the surgeons, I made that question like for all the 6 interviews that what is the role of the family physician, because that becomes very important. But for the patients, it all depends upon about the interview. So like for example, like I would say like not every single time that I have to change the question, like I have to add the new question uh, depending upon the discussion. But in terms of the analyzing, in terms of the coding, we basically code at this with the same like in the same way, the way we have done our semi-structured questionnaire. If the meaning matches like with the new with the new question that we have added, if that information matches with certain theme or certain meaning with like the questions that we have already that was the part of our initial questionnaire, we're gonna put them with the same themes categories. So we don't treat those questions, that information separately. The goal is basically to combine all the categories, make a link between their patterns, their meanings. So that is the goal. So for that reason, you don't analyze them separately.
Thank you.
My pleasure.
Any other questions? Well, I have another question regarding
Sure.
to content. So if the patients, it felt like the patients came with the expectation of getting better, like the surgery would be a panacea to their pain. So do you think the decision is already made at home before they come to meet the surgeon to get the surgery?
So that was basically sometime, or actually in this study, that was the case in most of the time, because when patients because of their previous pain, suffering, poor quality of life, they have tried their medication, they have tried physiotherapy. So now they are all ready. They want to get rid of this pain. They want to get rid of those disability, that stress that they are having. So like as I said, like most patients when they walk in, they wanted surgeons to operate, like to do the surgery. So the thing is that like in qualitative study, we do not report our data in terms of numbers or proportions, particularly when you're doing the qualitative studies. So we usually go with most or some, like those are the terms that we use. We do not report them. But just to answer your question, if I interviewed 12 patients, I would say that almost 7 or 8 patients, they already wanted their surgeons to offer them the surgery. So most patients, or majority of those patients, they already walked with this, like already they have made that decision. But you know that a lot of the time, like surgery is an invasive procedure. There's always some fear is involved with it. When you get that, okay, surgery is that, so you still need some time to discuss. You need time to know like what is happening, what's going to happen. You want some second thoughts, or second opinion. So that is also then like that is also the case was in our data basically.
Well, thank you for the answer.
My pleasure.
Any more questions from the audience? Well, we have 4 minutes to spare, so if there are no more questions, then we will give the 4 minutes back to you. And
No
thank you so
problem.
very much, Dr.
My
Rehman,
pleasure.
for your presentation and very informative.
Thank you
We
very much.
will
Well, my
try
pleasure.
to.
I really
Sure.
appreciate that you guys gave me the opportunity to talk about my research, and it's my pleasure to present, and I will be happy to present in future if needed.
Absolutely, that was my second question. So we will definitely reach out to you again to,
Sure. My pleasure.
to present to us. Well, thank you very much. And with that, we end today's session. Thank you
Thank
very
you.
much for
Have a good evening.
attending.
Thanks. Bye.
You too.
Bye.
Bye-bye.